Hello guys, welcome back to a new video of Medical Minute channel. So my name is Akash. So today we are going to deal with chronic myeloid leukemia, and we are also dealing with other hematology lectures from pathology also. So what is chronic myeloid leukemia? The name itself says chronic. Chronic means it is taking more time to form. Myeloid series is involved. Leukemia, cancer. Okay, chronic myeloid leukemia. Everything the name itself says. If it is acute. It is myeloid or lymphoid. You will come to know. Okay. Next, chronic myeloid leukemia. It is an acquired disease of hematopoietic stem cells that is characterized by one is leukocytosis, that is granulocytic immaturities are seen. Another one is basophilia. Basophilia is most commonly remember basophilia, which is seen only in chronic myeloid leukemia. Other is the splenomegaly and distinct chromosomal abnormality, that is Philadelphia chromosome. You already know this. Okay. Most common thing you should remember is basophilia. Okay. Chronic myeloid leukemia. Chronic myeloid leukemia is acquired disease of the hematopoietic stem cell. Leukocytosis is in, basophilia is in, splenomegaly and distinct chromosomal abnormalities. Age. Chronic myeloid leukemia is present in most commonly old age, that is greater than 50 years of age. Pathogenesis. Translocation, that is from 9:22. ABL BCR translocation, that is Philadelphia chromosome. ABL BCR is a hybrid gene, is a proto-oncogene having tyrosine kinase activity. Remember this tyrosine kinase activity. Now coming to the pathogenesis, which led to this of chronic myeloid leukemia. Okay, first ABL gene. ABL gene, which is ABL gene, its normal location is on chromosome number 9. Okay, ABL gene located on chromosome number 9. It translocated to the chromosome number 22, where it combines with the BCR gene, which is present on chromosome number 22, and from ABL BCR hybrid gene, which is also known as Philadelphia chromosome. This hybrid do a more potent abnormal signal transduction even without growth factors. They do not require growth factors, but still there is uncontrolled mitosis of the cells, leading to the chronic myeloid leukemia. Okay, ABL gene, which is present on chromosome number 9, combines with BCR gene present on chromosome number 22 and forms a hybrid gene which does not require growth factor and cause uncontrolled mitosis, which leads to the chronic myeloid leukemia. Remember, it is a reciprocal translocation. Means some part of chromosome number 9 goes to the chromosome number 22 and some part of chromosome number 22 goes to the chromosome number 9 and forms a ABL BCR hybrid gene is formed, that is Philadelphia chromosome. Okay, ABL BCR gene is a hallmark of chronic myeloid leukemia. That is, diagnostic criteria for chronic myeloid leukemia, there is 3 phases. Okay, most important viva question. Chronic phase, acute phase, accelerated phase and blastic phase. Chronic phase, less than 10% of blast is seen in the blood and bone marrow, and in accelerated phase 10 to 20% of blasts are seen. In blastic phase greater than 20% of blasts are seen. Please read these phases from Hirschman. Okay, so for better understanding. Clinical features, there are 3 important clinical features. First is due to the bone marrow failure. As there is chronic myeloid leukemia, the cells are continuously multiplying. Okay, which leads to the anemia. As there is more common symptom is anemia, that is why we are reading this chronic myeloid leukemia. Okay, anemia producing pallor, lethargy and dyspnea. Bleeding manifestation due to thrombocytopenia, means decrease in the platelet count, bleeding from the gums and other bleeding tendencies, and infections are quite common and include those of the mouth, throat, skin and respiratory and other sites. Symptoms are due to the hypermetabolism such as weight loss, lassitude, anorexia, night sweat. Another one is a splenomegaly. There is massive splenomegaly in some patient. It may be associated with the acute pain due to splenic infection. So what all are there? One is the anemia producing pallor, lethargy and dyspnea. Another is the bleeding manifestation, and next is the hypermetabolism. Because of that there is weight loss and lassitude, anorexia. Another is splenomegaly. Okay, massive splenomegaly, which may lead to splenic infection also. Next, coming to the laboratory findings. Okay, this is the same pattern we follow in every chronic myeloid leukemia, acute myeloid leukemia, everything. Okay, blood picture, bone marrow examination, cytogenetics, cytochemistry, other investigation. Remember this map, brain map. Okay, for writing the laboratory findings: blood picture, bone marrow examination, cytogenetics, cytochemistry, and other investigation. First, dealing with the blood picture. Okay, so how this slide appears. Okay, anemia will be normocytic, normochromic. Okay, it is like a normal shape and normal color. Thrombocytopenia, decrease in the platelet count. WBCs, okay, there is marked leukocytosis, increase in the WBC count, that is 2 lakh per microliter, and more at the time of okay, that is next is immature WBCs are seen. We will see myeloblast, promyelocyte, myelocyte, metamyelocytes and band form. Behind this in your brain, like myeloblast, promyelocyte, myelocyte, metamyelocyte, and band form. This helps in labeling in the diagram. Okay. Now another most important thing is basophilia. Okay, basophilia is seen in chronic myeloid leukemia. Basophilia is seen in chronic myeloid leukemia. Under eosinophilia, garden party appearance. After blood picture, we will go to the bone marrow examination. Bone marrow examination, cellularity, hypercellularity with total or partial replacement of fat spaces by the proliferating myeloid cells. Here the myeloid cells are continuously multiplying. Therefore, even the fat is replaced by these cells. Okay. Next is myeloid cells increase in the myeloid to erythroid ratio. Okay, remember myeloid to erythroid. If myeloid is increasing, then the whole ratio will increase. If if a myeloid and erythroid both are increasing, then the ratio will become normal. If only erythroid is increasing, the ratio will decrease. Okay. Here in chronic myeloid leukemia, the myeloid to erythroid ratio is increased. Erythropoiesis, reduction in the erythropoietic cells. In megakaryocytes, normal but usually smaller in size. Okay. Megakaryocytes gives platelets. Next, coming to the cytochemistry. In cytochemistry, reduced scores of NAP, that is neutrophil alkaline phosphatase, which helps in distinguishing chronic myeloid leukemia from leukemia reaction. See our another video where I have differentiated between chronic myeloid leukemia and leukemia reaction. Okay, a tabular column I have shown. NAP scores are very much important. That is neutrophil alkaline phosphatase. It is due to the NAP is present only in normal neutrophils. Okay, NAP is neutrophil alkaline phosphatase. Here the neutrophil are not normal, therefore NAP score is less in chronic myeloid leukemia. The NAP score is low in chronic myeloid leukemia. Other findings are due to hypermetabolism. There is increased serum uric acid level. Okay, hyperuricemia is seen. Hypermetabolism, you already saw na anorexia, lassitude. Okay. Next, coming to the most important thing. Okay, this is the diagram you need to draw everywhere. Okay, in this you have to show every myeloblast, myelocyte, promyelocyte, metamyelocyte, band forms along with basophilia and eosinophilia. Okay, this is the picture of chronic myeloid leukemia. Practice this diagram and draw in your exams. Okay, this will attract more marks. This hematological diagrams are more important than your writing part. Okay, with this we will finish chronic myeloid leukemia. Soon I will upload other parts also. Please subscribe Medico Manager channel and show some support. Jai Hind, Jai Bharat. Good night.